Okay, welcome everybody, and welcome to our board meeting in public. I would like to say a little bit about that, but I'm just going to wait until we've just heard from the apologies for absence from Iram, please.
Thank you, Nicholas. So I've got apologies from David Evans, Paul Smith, Daniel Carlton Conway, Jane Kinneborough and Heinz Shepper.
Fantastic, thank you. Any interests that have been declared other than what's already on the board website?
No,
I think we've also got apologies from Francis Shattuck as well.
Oh, thank you, Jane. Okay, thank you. And any interests to declare?
Nothing in addition to what we have already. Okay,
so just before we start, welcome to members of the public. I know that we have at least one person who's in attendance. We're about 8 months away from when the ICS is going to be established formally and by statute and will take on the functions of the CCG. I'd just like to point out we will continue as a CCG until then, but with the board meeting in common now having been established and the ICS taking on its shadow role from September, it really now makes sense to actually take business to joint meetings. And so these separate CCG meetings will come to a close. We have got our AGM scheduled for the 30th September, and we really feel that will be a great time, an opportunity for us to actually reflect on the life of Herts Valleys and to say our goodbyes. But bearing in mind that the work continues and that we are expecting a good deal of continuity in terms of people doing the work, as I said, this is the time to change. What I wanted to do today was just to signal this milestone and to really say that, in my opinion, we're actually moving into the next phase in a strong position in terms of what we've achieved. And it makes sense with the bill actually having been published and has actually had its second reading, that we now move into the next phase. And we've, I think, started to establish a great basis for the new ICS, with all our CCGs working incredibly well together. And on a more local level, our South and West Hertfordshire Health and Care Partnership is also working really well. And a lot of what you have seen discussed in those meetings will also be taking place at that local, more local level. I think it's remarkable, the strong partnership that we've already established. And I think we're all enjoying working collectively with everybody. It wouldn't go without saying that we've had, some challenging, but also some excellent board meetings over the last year. Meetings where people have provided, our members, our board, and also members of the public have provided genuine and great challenge. So some of these decisions that we've had to make have been very difficult. And I think we have always looked at those decisions responsibly and actually taken a lot of consideration. I know that some of you will have disagreed with some of them, but I'm still proud of our record as a board. And I'm pleased that our meetings have so often been enhanced by those members of the public. It hasn't always been easy, and we're keen to make sure that local people get a chance to ask their questions at the board, which we'll be coming on to in a moment. But I'd just like to say a big thank you to our public and to our board for their participation. So we're not saying goodbye to the CCG yet, and to its board members, staff and its volunteers. But I wanted to mark this moment and say thank you to everyone who's worked so hard to make Herts Valleys such a successful CCG. And we look forward to the next phase of our work to deliver improved health and improved healthcare for our local people. So thank you. Okay, so sorry about that little interlude. Minutes of the last meeting, Iram. Can I have approval? Yeah, and no other points of note. Questions received from the public, Iram?
Thank you. So we have received a question. I'm just going to read out the question and then pass over to Avni for the response. So with the recent press coverage in the Watford Observer regarding difficulties in patients accessing GP services locally by telephone, what impact do the board think this poor service at some surgeries is having on paediatric attendances at ED, which in this board pack are reported as high and many as potentially inappropriate? How is primary GP service access going to be improved in the near term to support the ambitious plans to provide a respiratory service to minimise unnecessary attendances at ED this winter? So I'm just going to pass over to Avni for that.
Yeah, it's a great question. So thank you very much for the question, Avni.
Thank you, Chair. So absolutely a prime question in terms of the current time. So I think thank you for the question. In terms of, it is recognized that throughout the whole pandemic, we continue to see a significant demand on general practice, and GP appointments have absolutely increased compared to the last 2 years in terms of the volume. Across the Hertfordshire and West Essex, we're seeing an increase of 9 to 17%, and that is variable across all the practices within the CCG as well. And in addition, that does not even include the e-consultations, which was embraced throughout the whole pandemic period. I think we've got to see this in light of our patient survey feedback as well, that was just published last week as well. So in terms of the feedback, Herts Valleys is, experiencing 86% of the patients have said that they've experienced good service within a GP in Herts Valleys, but 67% have found it easy to access. So there is room for improvement, undoubtedly. And I'm not, saying that, we've done everything that we can. So this is totally recognized in the work that we're doing, especially in terms of the demands on general practice, but it is multifaceted, and that actually impacts on pediatrics as well as adult services. What we are doing that would support some of this is, with the increase in the rise of the COVID variant as well, especially in children at present, we are obviously got our COVID hubs across the localities and looking at how they can be maximized in terms of opportunity. However, it is at this current time, the demand is outstripping the capacity. So to manage that a lot more across Herts Valleys for the imminent bit, I have approved a business case to increase the capacity in PCNs. That will be implemented as of from August onwards, which will provide extensive support on that. In addition to that, we've obviously, you can increase the capacity, but if you don't have the workforce, then how would you increase it? So we've got to work that in tandem. So working with our local training hub and the ICS hub as to how we support primary care and PCNs on the workforce and how they can actually look at recruitment plans as well. The last most important point is really the telephony bit. We are absolutely looking at all practices within the PCNs to see the scope of what that telephony infrastructure is. There are practices who have absolutely invested in this over the years when they've changed the model of care, but we're looking at how else we can support some of the other practices where demand is absolutely outstripping the capacity and the infrastructure needs to be supported through this. Telephony system is a practice responsibility. However, as a system, we recognize that we do need to look at how we can support this across all practices from Hertfordshire and West Essex, and looking at potentially the funds that we have obtained from NHS Digital, which are at present for Eastern North Hart CCG, but how that can be utilized across Hertfordshire and West Essex. So further details being coming through that. But the other most important thing, Gary, that I think you've highlighted from your email as well, is in terms of how do we actually change the perception and how do patients access the services above through this changing environment. So the comms and the engagement piece, which is underway at present, actually seeing how patients can access the best professional where possible is absolutely key. So working with community pharmacies, NHS 111 is absolutely one of the things that we're working through. But happy to share the detailed response by email as well.
Okay, thank you. I really hope that you feel that was a very detailed and thoughtful response. And I know that as members of the board and as GPs, we continually strive to improve. Trevor.
Yeah, I mean, I think we had this discussion earlier on in the board, but yeah, just to emphasise, I think demand is unprecedented, and the workforce hasn't really expanded with that, and it's the extra ways of working, including on-the-day telephone and online consultations, that have made access, harder than in the past. But yet we are providing more appointments than ever before, and as Avni alluded to, the GP survey relative to national figures in other areas, we actually perform quite well on. It doesn't mean there's not room for improvement, but I think we have to put it in the big picture and realise that we are performing pretty well.
Thank you, Trevor. Okay, we move on, and asking Jane, as David is away this week, to present the Managing Director's report, please.
Right. So I was going to take the report as read, but just try and draw out some of the key strands or themes for people to try and help us manage the time. So there's a section to start with, outlining some of the governance and leadership changes and progress that's being made, particularly with the local healthcare partnership, and that work continues, and we are trying to evolve that in an iterative way with the evolving ICS system-wide governance work at the same time. This was covered in part at our ICS Partnership Board on Tuesday, and indeed further work is taking place on that, so that we develop the elements together and holistically, rather than in splendid isolation from each other. The section on operational areas, again, I'm conscious that we have various points in the boards in common this morning already touched on aspects of this in particular, and we just have, in response to the question, primary care access and patient experience in primary care at the moment. So again, I wasn't intending to go through the detail, but there is a wealth of relevant detail that sits in that section of the report to underpin the broader conversations that we've been having. Thirdly, again, we have touched on COVID vaccination uptake and COVID rates at various points this morning, but you have presented here the most up-to-date figures for coverage of both first and second doses. And the current focus is very much on promoting uptake in younger age groups who have only relatively recently been invited, as well as encouraging older and more vulnerable groups who might not yet have completed their vaccination to do so, but in the face of really quite significant rising rates of COVID in the community at the moment. In terms of some of the development of planned care elements that follow, clearly elective recovery has been going relatively well. We expect there to be some interruption to that, particularly probably over about the next month or so, as those rising community COVID infection rates are translating through to increasing numbers of patients being admitted to hospital, which clearly then means that there are fewer staff, or indeed less physical space capacity due to the need to keep patients segregated away from known or potentially COVID positive patients. So we are anticipating some backward step in that, which we will obviously stay close to and try and minimise. Again, just drawing out some of the other themes related in particular to some of that earlier discussion. There's people will note in section 2.4 that there is specific reference to first contact GP and nurse assessment for children with respiratory related illness as one of the areas we are already seeing and expect to see more of is an uptick in non-COVID respiratory infections, in part probably because of a relative lack of immunity in younger children because of the impact of lockdowns and social distancing over the last year, but also linked to the relative relaxation of restrictions at the moment and greater social contact and social mixing. Just shortly to touch on the work going on, the considerable amount and extensive work going on in relation to developing stronger mental health services in a number of ways, in particular the work going on around adolescent services, eating disorder services, again the detail of which is summarised here. So just try and pick out the headlines. And I think the table that sits at the end of 2.5, I would draw people's attention to, because it's a good, I think, summary of how we are, despite the pandemic and the many other pressures, continuing to focus really strongly on patients with autism, with learning disability, and related pathways, and conscious that these are some of patients who often go least noticed in terms of focus on additional services or backlog and recovery. So Nicholas, I think that probably is the bulk of the operational elements that David's report outlines. The last kind of bit I would call attention to are the sections relating to workforce in section 3 onwards, in particular the work that's taking place to promote equality, diversity and inclusion, and as part of that overtly tackling racism, which is becoming an increasingly strong strand of that work, as well as the ongoing support to health and well-being of our staff, and indeed all staff across the health and care sector, who have been incredibly robust in dealing with everything that's been thrown at them this year, but in most sectors are now becoming increasingly tired. And we just, we need to balance, I think, as we've said before, balance that need for service recovery with a real understanding of the toll that the last 15 months have taken on our staff, and that we don't inadvertently further cause waiting time problems, waiting list problems by pushing staff too far and too fast. So I'll stop at that point, Nicholas, but happy to try and take questions or comments from board members. All of whom have heard enough of that now that they don't want to ask me anything on it. That's fine.
Nicholas, you're on mute.
Really not doing well today, am I? I was just saying the report's very full, so I think if there are no questions, then thank you very much, Jane, and we'll move on to the quality and performance report. And Claire, thank you.
Happy to have an extra few minutes. Thank you, Jane. The overarching quality and performance report was obviously discussed this morning in the board in common, so I won't repeat that. What I'm going to do here is take the report as read and just go through a bit more of a local Herts Valleys focus, and also some updates, because we have got some of the data in this morning for May, which will give you a better view on how the progress is going. So for West Herts Hospital Trust, the RTT, the May position is an improvement on in May of 75.6%, April was 72. So it is a small improvement, but it's going in the right direction. The number of 52-week waits continue to reduce as the result of the restoration of elective activity. The number of 52-week waiters have dropped by 20% compared to April, which is actually 33% lower than the peak we saw in February this year. The impacted specialties are the same, though there remain to be ENT, ophthalmology, and also TNO. The number of 52 weeks waiters, which is what we were asked before, was 1,162. And to put that in perspective, we are doing better than most in the region and also the country for that. The highest number at any one hospital, and I don't know which hospital it is, but I've been told it's 25,000. So 1,000 is actually, that just gives you some sort of like basis to see how well West Herts are doing on this. The number of patients waiting more than 78 weeks has increased. At the end of the month, there were 389, which is up from 352. The number of these patients have actually chosen to defer treatment for various reasons, COVID being one of those reasons that's still there as a concern. These patients are contacted on a regular basis to ensure there's no change in their decision, offer them earlier treatment if they then wish. The other thing is that outsourcing is continuing, and this has helped support immensely the delivery of the waiting times and a reduction in the waits. West Herts is working very well with our independent sector, and it has improved the situation for our West Herts patients. Royal Free London, the information I've got are for Herts Valley's specific patients, not for the overall. And they're still very challenged. In total, they've got around 10,000 people on their waiting list, but they are making progress. We are aware of 693 Herts Valley's patients waiting over 52 weeks, but that is an improved position from 867 in April. So we are seeing it heading in the right direction. The number of 104-week waiters at the trust impacting Herts Valley's patients is 60. These are mainly in plastics, so around 40 in plastics, and then some in dermatology and gastrology. They've got a accelerator system program in place, which is actually working really well, and it's focused on improving actions required to get people through. And the activity is also up in the independent sector. They're starting to use that a lot more, which we've seen the benefit of with West Herts using as well. And the trust is actually meeting the trajectory that they've set out on their plan to address the waiting times. We will have some further information regarding the 104-week waiters at September QMP. We've got a meeting next week with them, and so we'll have some more detail that we can report in there. I'll move on to cancer. Unfortunately, only one of the cancer waiting time standards was achieved in May. However, there was a slight improvement on the previous 2-week wait performance to 83.5, but the target is 93, but we are moving in the right direction. The 2-week waist breast symptomatic performance has increased from 18% to 49%. So quite a, as you can see, with progress is being made. It's not where we want it, and we're working with West Herts on it. Referrals into West Herts remain high, and also they're above pre-COVID levels. Therefore, the performance is challenged, not only because it's a bigger impact, but also the backlog. So to keep moving forward is really good. The clinical harm reviews are occurring for all breaches that hit 62 days and 104 days in cancer. And the process we've got in place, as discussed at this morning's board, is across the system. And we have actually got very good transparency with West Herts and the conversations about potential harms, and we've not seen any as yet. Diagnostics, which is obviously very linked to cancers and other waiting lists. Performance has improved in May to 83.5, you'll be pleased to hear. There has been a loss of the MRI activity at Hemel, which does affect performance, but they're sourcing additional capacity from the independent sector again, and they're reviewing whether they can include another provider from the end of June, I think it is, to again increase that capacity they've lost in Hemel. They're waiting for a new machine, that their current one has worn out. They do after about 10-15 years, so if anybody's wondering why that capacity has been lost. The other area I'd like to touch on is HUC. I won't go into too much detail. We did have some information this morning, but in the West, we're still seeing continued pressure. Workforce remains a risk. The volume of calls have increased, but we've reviewed in the quality team, and we are having low numbers of complaints. We're getting good professional feedbacks, and also we've had low SIs, which is also good, but we'll continue to monitor that to make sure that that continues to be the position. The only other area I think we need to mention is the patient safety. We have got quite a few outstanding serious incident investigations due for West Herts Hospital Trust, but they have now employed more people to do the investigations, and they have got a plan and trajectory to get back up to a 0 outstanding SIs. They are working through them, and they're taking thematics of the outbreak situations, the COVIDs, which have increased. I think, obviously, with how many outbreaks we had, there's quite a lot of work to do there. I think that's probably all I want to mention and the update, but I'm happy to take any questions.
So thank you, Claire, for that really comprehensive report. Questions? Rami, please.
Yeah, Claire, thank you very much. It's quite a lot of very good work in very challenging times, without question. And although the figures do have this red, the differences are not tremendous. The one thing that I would ask is, with the 104-week waits, the 60 people you referred to, in addition to the potential problems physically, there is obviously going to be the stress of waiting. Are primary care doctors informed of who these are, so that we actually have some insight and can support them if they have concerns, and obviously escalate those concerns if they occur? It's a small number, but it's obviously quite a long wait.
Rami, that's a really good question. I do know that all the waiters are spoken to, but I'm not sure whether it gets fed back to the GPs. I will actually follow that up for you and give you an answer, hopefully by tomorrow. But all of those patients do get called, and they have that wellbeing system check as well on them while they're in the queue waiting.
Okay, thank you, Rami. I don't see any other hands up, but I might have lost that function on my computer. Oh, Kate, there you are. I can see Kate's name appeared. Thank you.
Hi. Thanks, Claire. I'm becoming a little bit concerned. The reception staff at my surgery are weekly reporting issues with the East of England ambulance service, particularly around delays for non-blue light ambulances. So, you know, transfers to hospital that don't necessarily need a crash call, but do need to get to hospital. And on a weekly basis, they're saying to me that there's 10 hours, 12 hours, sometimes calls that can't even be accepted because of huge delays there. Is there anything you can tell us about what's happening at East? Or
yes, I can. Unfortunately, East have actually today gone into what we call REAP 4, which is their highest level of escalation. So they're standing down all non-essential meetings and other activities and focusing on the urgent 999 calls. It is actually a pattern that's happening across the country. That isn't an excuse. It's not to make anything better, but it is something to bear in mind, because we can't pull on resources from neighbouring trusts as we sometimes do when we're in this situation. I do know Ian Armitage and the urgent care team are working really hard to see how we as a system can help support, and we've actually stood up the Hertfordshire Health Economy Tactical Command Group tomorrow, which we do in conjunction with East and North Herts CCG, to have a system call, because we do realise that the impact of this is quite serious, and we want to know what actions we could potentially put in place as a system to support not only East but the other providers, because it's, as you know, it impacts on everybody. We are working with the trust as well around delays to flow, to make sure that we get the time around as fast as possible also. So I think I've given you a solution, but what hopefully I've given you is the fact that we are aware, and we are actively working with them to see what we can do as a system to help mitigate.
thanks, Claire.
Thank you for that. Trevor.
Oh, yeah, thanks, Claire. Really comprehensive report. As Rami said, lots of information. Just a quick one on something you did mention. The MRI scanner at Hemel obviously reached the end of its life, and the mitigation at the moment seems to be short-term outsourcing. Is there a sort of longer-term plan to replace this capacity or not?
I believe there is, but I don't have any of the details, Trevor, but I can get that for you. But yes.
It's quite useful to know the sort of medium to long term, because obviously in terms of hospital developments, that's quite a way down the line, and you probably need to know what's happening in between, now and then.
And I know Gemma knows the detail. I don't think Gemma's on the call, is she? I'm sure I saw something from her. But no, I'll get the detail to Trevor.
Thank you very much.
It is in hand and being discussed.
Thank you.
Thank you. Any other questions? Is that a no? I think it is. Yeah. Okay. Claire, I just wanted to record our thanks to you and all of the team. I know that you're now obviously working very much and very closely with Jane Kinneborough, who's our board lead, but you and the team have been tireless and will continue to be tireless in looking to address all quality issues. So a big thank you from all of us for that. Thank you. Okay, we just move on to the last parts. Sorry, did somebody want to come in? Stuart, sorry.
Do you mind if I just drop something else in?
Stuart, please do.
Seeing we have a bit of time to Jane, actually. Sorry, hang on. Is that any better? I was getting an echo, sorry. Nicholas, you mentioned that we're developing onwards with the partnership board, which is great. And Jane mentioned this morning about the ICS board, and I think we talked about the partnership board and ICS in coming live in September in shadow form. Clearly, the impact of not knowing about the boundary issue, and I know it's something out of your control, but we have been told for about 2 months now the decision is coming, and we're still waiting on this. But it must have an impact on your ability to put organisational structures together. How can you put an organisational structure together for the ICS, the partnership board, and promise everybody that they're going to have a job within those structures when we don't know what jobs are going to have to be filled by whom? And it must be a concern to staff in terms of their morale and their future. So whilst we've got a few minutes, perhaps I'd like to explore that issue, if you don't mind.
Yeah, shall I start with that, Stuart? So you're right. We have been hoping, anticipating that there would be a decision one way or the other on the boundaries for some time, and obviously the recent change in personnel at the Secretary of State level, it probably has contributed to that taking a bit longer. We are aware that today is the last day of Parliament before they rise for the summer recess. We remain hopeful we may yet hear even later on today, but you're right to flag it as an area that intrudes on detailed planning. That uncertainty notwithstanding, we have done an awful lot of things, and if I just sort of pull some of the relevant ones out, we launched last week an intranet for all staff across all 3 CCGs, which brings together and will be regularly updated with information about progress of the bill, about guidance as it's issued. We understand that there is a raft of guidance ready to be issued once the boundary alignment has been resolved. So we've set that up in advance as a place that people can go to have a common source of information. Similarly, we've been doing regular briefings now with all staff across the 3 CCGs, myself, David, and his opposite numbers, Sian and Peter. We started that in May, and those have been well received, and they are complementary to the ongoing regular internal briefings within each of the CCGs. So at a practical level, we are trying to progress those sorts of staff information communication support elements. we have also, there have been discussions going on, just high level discussions, but with colleagues in Mid and South Essex and Suffolk North East Essex, the two others that have parts of Essex in their ICS, to think about and have outline plans for how we might support the next stage of work, including with staff, in the event that the boundaries are determined to change. And we've also done quite a lot of work to be really clear. It's not an issue for Herts Valley CCG specifically, but for those staff who are in ICS roles, but maybe on the payroll of West Essex CCG, which has been operating as the banker, that we're clear about the difference between West Essex CCG staff and ICS staff on the payroll of. So there's a lot of practical stuff going forward. As we referenced earlier on, a lot of stuff around the broad shape of the governance. But I think there's a championing at the bit now to get on and mobilise. But I'll stop at that point. But hopefully gives you a flavour of some of what's happening.
Yes, just to be sure that everybody was told that there's a job for everybody, regardless of how we move forward.
So staff who are employed below board level have been told that, and that is very clear, that there is no, we can't absolutely promise it will be exactly identical to what you do now, but there will be a job for everyone that will be at the appropriate grade and alignment and all of that. Clearly, we can't take we can't give that commitment at board level because the board structure is significantly different for an ICS board.
Thank you.
Nicholas is
my mute button's gone mad. I was only going to say Thelma, so there we are. Over to you.
I thought so. I was reading your mind. Jane, when I raised this issue some time ago, it was very difficult for you to answer it because there was so much uncertainty. Now we've got the bill and some semblance of guidance. I wondered whether you were able to say, do we now have, or the beginning of, a master plan which puts together all the things that we've got to do. I know a lot of work is being done, but so that one can actually see, have a helicopter, see everything that's being done, who's involved, etc., and where, as lay members, we can have an input. And also, has any thoughts been given to the process for recruitment of new board and committee members, if you've got to that stage? Thank you.
Yeah, so again, a couple of things. We had already made the decision to recruit a fixed term senior person to be our transition program director, and Matt Webb, joined us 3 weeks ago. So in terms of being able to put more detail into both that master plan, but also the individual plans that sit underneath and aligned to it, that's absolutely what Matt has been getting his head around in these first few weeks. And clearly the work that Simone and the governance teams have been doing now for months is part and parcel of that, and continues. We have, in terms of the establishment of the ICS NHS board and the ICS partnership, we have had some further high-level ideas and discussions, but until we see the guidance that I just alluded to confirm that what we are mandated to do and what we are free to do, those remain high-level ideas at the moment. But again, as soon as we are in a position to start to move ahead with that, we will be. 2 additional points linked to that. It's not at this stage wholly clear how appointments will be made, and how there is a reference in the bill to nominations. So some will be appointments, some will be nominations. Even where there are nominations, I'm presuming there will need to be job descriptions and competency frameworks and those sorts of things established. Being really practical, until we have the go-ahead on the boundaries, actually none of this can start, because it starts with the recruitment and confirmation of chairs designate, who will then go on and recruit and confirm chief execs designate. And until we know what we're trying to recruit people to. We can't start that. So we are as keen as mustard, Thelma, to get on with this.
I understand chicken and egg. Thank you so much for the updates. Thank you.
Okay, Trevor, thank you.
Oh yeah, sorry. Sorry, I'm just going to backtrack a fraction with a quick question for Claire, which is, I suppose, topical, which is why I then thought of it a bit later. You've given us some figures for the long COVID service in our area, which are really helpful, and it's good to see it laid out in how it works and where it's referring people. I suppose, you know, with this sort of anticipated increase in demand, especially among younger people, I think, and anecdotally, I've heard some stories about sort of quite long waits. I was just wondering if we were monitoring capacity on that.
So in specific to long COVID, sorry, Chair, do you mind if I take that? Just jumping straight in. On specifics to long COVID, it's quite a new service, as you're aware. And we're actually just developing what they're going to be reporting on. So as you can see in here, we haven't really mentioned about how long we're waiting and the capacities. What we are going to do in the September board is have more detail. This just says what they're doing now, and I absolutely appreciate that. And we're just working at the moment to get that level of detail through. We haven't got the automatic systems to update at the moment. So that will be one of the things we will be asking, is the waiting list and waiting times. So that will be, hopefully you'll see that at Quality Committee in September.
Nicholas, can I add something to that?
Yeah, very quickly, Karina, Richard, and then I do need to draw a line because we must finish on time. Thank you.
It's about the long COVID, that's why.
Yeah, sure. Karina, yeah, go ahead. You're on mute now.
Sorry. Trevor, the only thing I want to add is that we have recently, by that I mean about just over a week ago, had confirmation from NHS England for additional funding to expand the long COVID service. So we are negotiating with the main provider, COCH, how we're going to do that. I think we've agreed a plan now, and this is going to come to clinical exec for approval next month.
Okay, thank you, Karina. And then the honour, I don't know if it's the honour, Richard, the last question of the last board meeting in public for Herts Valleys. Richard.
Oh, Nicholas, I feel unworthy, but anyway, I'll go ahead. It was the long COVID point, really. As most people are probably aware, there is going to be a long COVID enhanced service anyway, which primary care can sign up to. And I suspect in reality that the specialist long COVID service that currently exists is not going to be able to cope with anywhere near the numbers that are going to be thrown at it. And I think the future will be partnership working with primary care, whether it's per locality or per PCM, per practice, helping patients who are less severely affected, and working closely with long COVID, perhaps for the most severely affected patients who need the most specialist input.
Okay, thank you. Okay, so we just finally move into that was an attachment for assurance. So I think we've had a good discussion there. Thank you, everybody. Review of conflicts of interest and how they were managed. Iram, I don't think there's anything over and above. I mean, we did obviously have a discussion about general practice, and of course we're all conflicted, but also hopefully part of the solution. In terms of equality and diversity, I think that, you know, the discussions covered much of that, and I know, Jane, you certainly mentioned that in your report. So, Iram, I'm just double checking whether you identified any new risks.
No new risks identified.
Lovely. Okay. Okay, so thank you very much, everybody, for all of your help over the years. We're still going to continue to be meeting jointly with the other two boards rather. And so thank you very much. And I think it's au revoir, goodbye, or whatever else you want to say. Thank you.
Dabbing my eyes in sympathy.